You can start sharing your screen.
Right, well, thank you very, very much indeed for that introduction. And I hope you all find that this is a productive night. We come from different backgrounds, so we all see the patients with neck pain, but our approach to them will vary as our treatment approach to them varies. So the title, how can we lessen the need for surgery? I suppose in a nutshell, I'd say if we can slow or reduce disease progression, that will decrease the need for surgery. And then the second question is, well, how can disease progression be slowed? And we can look at primary prevention, or as I'll talk to tonight, we need to do adequate rehabilitation at the appropriate time. You're probably aware of the global burden of disease studies, and I think that clearly shows the problem that neck pain is. That neck pain for both women and men are in the top 10 of 354 chronic disorders, and for the metric of years lived with a disability. So in other words, neck pain comes with high personal and societal costs. Most importantly, we must appreciate that neck pain is a recurrent disorder. And this was the Bone and Joint Decade Neck Pain Task Force, over 10 years ago. But they described the course of neck pain as episodes occurring over a lifetime with variable degrees of recovery in between episodes. So if we look at the current model of care for neck pain, basically neck pain tends to be treated as a series of separate episodes, not as a recurrent disorder. So the focus is on pain relief. So once the pain has gone from an episode, the patient is regarded as being okay. And indeed, that matches with some of the current clinical practice guidelines for neck pain disorders, which recommend that you give the patient advice to stay active and education, and that this is the sole first line of treatment, provided there's no major pathology. But, recent systematic review has shown that treatment of advice to stay active and education gives minimal to negligible effect on pain and disability. In other words, it's counting on the natural history of the pain to decrease with time. It's certainly not doing anything very active. But this approach to treatment, where we just look at an episode and say it's better when the episode has gone, ignores this problem of recurrence. And remember, it's recurrence that's the real burden of neck pain. And studies over time have shown that 50 to 85% of people who experience an episode of neck pain have recurrences within 1 to 5 years, or they have continuing neck pain. What I'll be emphasising tonight is that staying active, the advice to stay active results in minimal to negligible improvement in any of the impaired neuromuscular and sensorimotor control that occurs with pain and injury. So it does very little for the pain, and it does virtually nothing for the muscle system or the sensory motor system. So what I'd be proposing is that rehabilitation of cervical neuromuscular and sensorimotor control offers probably the best opportunity to slow or lessen disease progression. And that's certainly from a physiotherapist's angle. I would emphasise again that staying active isn't doing much, and rehabilitation of the impaired neuromuscular and sensory motor function requires specificity and training. And we'll talk about that. So we'd also propose that rehabilitation is part of management from the first presentation. and that our outcomes were not just concerned about relieving pain, albeit very important, but we're also looking at prevention of recurrent episodes and that transition to chronicity. So what I'd like to talk about in this presentation, I'm going to do a very brief review of cervical neuromuscular and sensory motor systems, and then I'll do a brief look at the research that we've undertaken into the nature of impaired neuromuscular and sensory motor function. I'll provide some evidence that the systems do not recover automatically with pain relief. I'll also provide evidence for the need for specificity in exercise. It's not just telling people to do some mobility exercises. And I'll finish off with a proposal for a different model of care. So this is anatomy, basically going back to anatomy 101, but a couple of important features. That 20% of the stability in the cervical spine is supplied by the ligaments. And that's at end of range. So only 1/5 of the stability is supplied by the ligaments. 80% of the stability is supplied by the muscle system. And it needs that stability in our mid-range postures where we mainly function. And another important thing is that the muscle system is the only internal system able to substitute for changes in articular integrity. Now, if we think about the cervical neuromuscular system, there is a topographical arrangement of muscles. In other words, we have muscles that act over the craniocervical region. We've got other muscles that act only over the cervical region. And then we've got muscles that act over both regions simultaneously. And the other interesting topography is that we have deep and superficial muscle layers. And there is some functional specificity between these deep and superficial muscle layers. So the superficial muscles, for example, like sternocleidomastoid or splenius capitis, have great torque producing capacity. And in fact, if you were to lift your head off the bed, 87% of that flexor torque is supplied by the sternocleidomastoid. So these muscles are very important for the support of the head and neck. But unfortunately, they're not arranged anatomically to provide segmental control. And as you can see, the sternocleidomastoid and the mastoid process down onto the clavicle, it's nowhere near the actual cervical segments. So we have this deep sleeve of muscles enveloping both the craniocervical and cervical regions. And these muscles do have the appropriate morphology and composition for control of segmental motion and support of the cervical curve. So these muscles anteriorly are longus capitis and longus coli, and posteriorly multifidus, semispinalis, cervicus, etc. So you've got this deep layer and this superficial layer. Now, all muscles are important for motion and support, but if we think about just the erect posture, we require adequate strength of the larger torque-producing muscles to hold our head against gravity. If we didn't have these muscles working, muscles like sternocleidomastoid and the superficial extensors, we couldn't hold our head up against gravity. But if we've got activity in the superficial muscles without activity in the deep muscles, as was shown by Winter and Pillay a long time ago, this will lead to segmental buckling, or in other words, segmental instability. So we need this appropriate balanced activity between the deep and superficial layers of the flexors and extensor muscles. And that's an important concept because it underpins a lot of our research into the impairments and also the therapeutic exercise. because the central nervous system actually uses different strategies for control of the deep and superficial muscle layers. So, for example, movement's quite a simple one. In the active extension, you can see here that we get bursts of eccentric activity of the sternocleidomastoid, and that's on lowering, well, taking the head back into extension. But then the semi-electrical silence, and we get this other big burst of activity to try to bring the head forward. In contrast, the deep muscles have a continuous activity. So they have more supporting activity, and these have the torque producing activities. The muscles act differently when they've got to stabilize the head. So this is an experiment that we did and published quite recently, where the person had to actually balance a little ball on this platform on the top of the head. And then the task was made more difficult by making the board more slippery. But we can see the different control strategies here. So these are the superficial muscles. So the more difficult the task became, they increased their activity. Whereas you can see with the deep muscles that they reacted from the first to the second degree of difficulty. But after then, they didn't really change substantially as the task got more difficult. So they, again, were doing a stabilizing. They were sort of doing a tonic sort of activity, while the more superficial muscles were actually guiding the movement of the head to keep that ball stable. And we see the same sort of thing with an experiment by Bexander on eye-head movement control. So this is looking at, well, it was looking at movement of the head, relative movement, muscle activity, sorry, in the neck relative to eye and head movement. But the thing I want to show with this is sternocleidomastoid. So for example, when we rotated to the right, the left sternocleidomastoid worked, the right was pretty silent. But if we look at the deep muscles, such as the obliquus capitis superior and inferior, their activity level didn't change regardless of whether they were turning to the right or the left. So again, they were offering the support while the larger movements, the larger muscles actually produced the torque. All right, so let's just also look briefly at sensory motor control. And if in that, the neck, along with vision, the vestibular system, and the skin for touch, provides important proprioceptive information in the whole of sensory motor control. But the neck is a unique region. So unlike, say, proprioception from the ankle, shoulder, knee, hip, or back, the neck has direct connection to the inner ear and eyes. It has the highest percentage of muscle spindles anywhere in the body, those particularly in the suboccipital muscles, and there are reflex connections to the eye and inner ear. And what those connections subserve is that they're important for knowledge of the head in relation to the body, for controlling postural stability and balance, and then importantly for eye-head coordination and oculomotor control. So those muscles have got to do fine adjustments of our head to subserve our vision. And if a patient does have impaired cervical sensory motor control, they'll often report symptoms such as lightheadedness, dizziness, unsteadiness, or blurred vision. All right, so if we now move on to looking at the nature of the impaired function in the neuromuscular system in neck pain disorders. Everybody would be well aware, and there's tons of research that shows that with neck pain, there's reduced strength and endurance of the craniocervical and cervical flexors and extensors. So that's a well-known fact. But research over the last 20 years has had quite a focus on neuromuscular control. And indeed, neck pain and injury can cause extensive changes in cervical neuromuscular and sensory motor function. So this is a deliberately busy sort of slide, but there are an enormous variety of changes in control strategies, as well as changes in muscle properties. And together, they cause a patient with neck pain to have altered motor control, altered proprioception, and then limited endurance of their muscles, greater fatigability, and less strength. Now, rather than go through all of these, I've just selected a couple to sort of illustrate how the coordination or the muscle behavior changes with neck pain. So the first thing that I'd like to show is the interrelation between the deep and the superficial neck flexors. So this is called the craniocervical flexion test. And basically, it's just a test of craniocervical flexion or a head nod. And it's the anatomical action of the deep cervical flexors. It's not the action of sternocleidomastoid. Sternocleidomastoid is a powerful flexor of the neck, but due to its attachment to the mastoid process, it's actually an upper cervical extensor. So that when we ask patients to do craniocervical flexion, we don't expect much activity in the sternocleidomastoid. Now, all these numbers, just basically what we do in the craniocervical flexion test is that we use a pressure sensor and we ask them to target 5 points of increasing pressure, or in other words, of increasing inner range. Now, this is a healthy participant, and you can see, true to an anatomical prediction, that the activity in the longus capitis coli increases as the task difficulty increases, as we move further into inner range. And then, as we predict, there's very little activity in either the anterior scalenes or sternocleidomastoid. However, if we look at a patient with neck pain, we can see that the pattern just changes. They have great difficulty in activating their deep cervical flexors, and we've asked them to do a certain task, so they try, and they use a different muscle strategy to use it. Now, to measure the deep neck flexors, we built an electrode into a nasopharyngeal tube and then suctioned it onto the back of the throat. But as you can imagine, for clinical studies, it's difficult to get participants when you're doing that sort of measurement. It's not pleasant at all. So what we do, and we've also shown that the greater the activity in the sternocleidomastoid, the lesser the activity in the deep cervical flexors, or conversely, the lesser the activity in the sternocleidomastoid, the greater the activity in the deep neck flexors. So in the clinical situation, we have just used a surface EMG to measure sternocleidomastoid activity. But the thing to point out, for example, here is an asymptomatic subject. These are neck pain groups. So in the craniocervical flexion test, we're showing that there is this greater activity, this change of pattern. And it doesn't matter what sort of disorder it is, the deep neck flexors seem to become inhibited and weak for the patients complaining of cervicogenic headache, whiplash, mechanical neck pain, occupational neck pain, whatever. So it's almost like the quadriceps, what the quadriceps is to the knee, that it doesn't matter what condition you've got, this muscle reacts quite profoundly. Now, the cervical extensors lose their strength and endurance with neck pain, we know that, but there's also a tendency for, similar to the cervical flexors, for relatively greater impairment in the deep cervical extensors. And we can see this here in this isometric extension, that multifidus and semispinalis cervicus, which are our deepest neck extensors, have much less activation than the healthy subject. And conversely, they'll increase their activity in splenius cervicus, the deeper one, the more superficial one. The pattern is not as strong in the extensors for this imbalance between the deep and superficial muscles, not as strong as the flexors, but it's there. Then another important change in motor control is the altered directional specificity in the cervical muscles. So what the subject is required to do is on instructions to push forward, push backwards, or push to the sides. So if we look at the control subject, so here they've been asked to push forward. In other words, you'd expect sternocleidomastoid to work, and it does. Here they're into extension and extension lateral flexion, and that's where you'd expect splenius capitis to work, and it does. But in the patient with neck pain, you can see that when they're asked to push into flexion, not only does sternocleidomastoid work, but the extensors come in. And the same sort of thing happens when they're asked to extend, the flexors come in. So the neck pain patients tend to have this massive co-contraction when they're asked to do things rather than have directional specificity in their muscles contractions. And there are several other different experiments showing this greater co-contraction of the flexors and extensors with neck pain. There's also changes in the timing of activation of the neck flexors and extensors. So this is an experiment where we looked at the feed-forward response to a perturbation caused by a rapid arm movement. So if we see in our healthy subjects, this is anterior deltoid, deep cervical flexors, anterior scalene, sternocleidomastoid. And so in a healthy subject, the instant that the arm begins to move, all the flexors come in simultaneously. And that's to stabilize the head during that, in that perturbation. We don't want our head moving. But what happens in a neck pain patient, you can see that the arm begins to move, but the onset of the deep and the superficial flexors is delayed. So the movement occurs, but there's a delay in the activation of those muscles. And these delays have also been shown in another experiment where the perturbation was at the foot. And then depending on the direction, you can see that the sternocleidomastoid, for example, came on later in the neck pain patient than it did in the healthy control. And the timing depends, as I said, on the direction of the perturbation, but it's basically showing exactly the same thing. So what's the relevance of these altered muscle behaviors? Why do I sort of get a bit fixated on them in a way? Well, if we think of control of static and dynamic postures or movements, we were saying that we needed good interplay between the deep and the superficial muscles so that you've got adequate segmental support and then adequate support of the weight of the head. But we can see that our neck pain patients don't have this adequate support of their actual spinal column. We also know that when we lift our arm, the neck moves and the segments of the neck moves. So this was a study that mapped the movement as the arm was abducted to 0, 30, 60, 90 degrees abduction. So that's a normal response, and it's one of the ways that the neck copes with the forces imposed on it by the weight and activity in the upper limb. But we just saw that when the arm moves, that the deep muscle or that the muscles don't come on instantly. So in other words, this movement has already occurred before there's any muscle support in the neck pain patients. So it's not surprising that about 80% of patients report arm activities aggravate their neck pain. So this is some of the reason why I think it's crucial that neuromuscular function is rehabilitated. Now, a brief word on sensory motor control. As I said, you suspect that there's problems there when the patients are complaining of these sorts of symptoms. And sensory motor disturbances commonly present with patients, whiplash-associated disorders in particular. They almost all have deficits in sensory motor control. Certainly in a high proportion of your patients with idiopathic neck pain, obviously with people having cervicogenic dizziness, and also post-concussion. And what what the research has shown us is that they'll have troubles with cervical joint position sense. They also have poor cervical movement sense, poor balance, poor eye movement control, and poor eye trunk head coordination. Now, the problem is that there's absolutely no guarantee that the neuromuscular and sensory motor deficits will resolve as pain or the other symptoms resolve. And as I mentioned before, there's certainly no guarantee that these deficits will get any better by just staying active and range of motion exercises. So here's a couple of studies. This was a study of whiplash, and this is the EMG in the craniocervical flexion test. The main thing to notice is this is the healthy control. This is people with quite high levels of pain and disability. But the most important one is this one, because this group are the group at 3 months who said, we fully recovered from our whiplash injury, no pain, back to normal, but their muscle function wasn't back to normal. It's the same. This is a study looking at the treatment of cervically related lightheadedness and unsteadiness. So the manual therapy to the neck decreased the symptoms of lightheadedness and unsteadiness. But when we objectively looked at balance, there was actually no difference in the balance measures. So in other words, the pain or the symptoms resolve, but the impaired function persists. If we keep thinking of recurrence, this is not getting, the impaired function is there. And indeed, there's a whole series of studies being undertaken at the University of Birmingham, and they're looking at people in remission. And even individuals in remission with neck pain, they showed that they can be discriminated from asymptomatic controls because they've got altered velocity and poor smoothness of neck movement, or performance in the craniocervical flexion test. In other words, their deep neck flexors are not activating well. They've got reduced neck flexor endurance. And as we saw before, excessive co-contraction of the neck flexors during neck extension. So this co-contraction or tendency to co-contraction remains. So these deficits in impaired neuromuscular control are there in remission. So relief of pain, staying active, range of movement exercises, resuming everyday activities doesn't guarantee that neuromuscular and sensory motor deficits will resolve. So we need exercise for them in rehabilitation. And what I'd present now is that we need quite specific exercises. To actually show that you needed particular exercises for particular dysfunctions, we looked at 3 different, we and there are other people as well, looked at 3 different methods of training. So motor relearning training, endurance strength training, and mobility training. So 3 different forms of exercise. And we used cervical flexor function in the outcome assessment because it's quite an easy measure to do. So our outcomes were the motor control in the craniocervical flexion test, timing of muscle onset with arm movement. We looked at the flexor endurance and strength, and we also looked at range of movement. So these are our outcomes, and we looked at how did these different training regimes affect these outcomes. So the first one was motor control in the craniocervical flexion test. And what we were able to show there, that motor relearning training improved the altered behavior that we can observe. So again, pre-treatment, the patients can't activate their deep neck flexors and overuse their superficial flexor sternocleidomastoid. But with rehabilitation, they could then activate their deep neck flexors, and so they reduce their activity in the sternocleidomastoid. In other words, their pattern between their deep and superficial flexors was normalized with a motor relearning regime. Strength training did absolutely nothing. And this finding was reinforced in O'Leary's subsequent study, where again, strength training didn't change the activity in sternocleidomastoid during the test, during the craniocervical flexion test. Mobility training didn't change it at all. It was only the specific motor relearning program that reduced the activity. So that's pre to post. So showing the same thing. And again, when we looked at the timing in the perturbation with the arm movement, in the motor relearning group, 80 to 90% got an improvement in the activation, in the timing of activation of their cervical muscles. Whereas again, in the strengthening exercise, it was 50-50 whether they got an improvement. So their improvement was no better from chance. But if we look at strength and endurance, so before it was the motor relearning that was having the effect, but the low load motor relearning does absolutely nothing for strength. So you need to strengthen the muscles. We need to do higher load exercise to address that problem. And again, O'Leary found the same thing, that motor learning and mobility did nothing to improve the endurance and did really nothing to improve their strength. And when we look at range of movement, well, all forms of exercise benefit range of movement. And interestingly enough, the motor relearning does quite well. But one of the most amazing things I thought of this experiment was that the range of movement exercises, which is the most common form of exercises prescribed, have very little effect on our muscle function. So if we look at cervical related sensory motor control, again, we can see the need for specific training. And this is a clinical trial that we've submitted for publication just recently, where we looked at the effectiveness of adding rehabilitation of cervical related sensory motor control to a regime of manual and therapy and exercise for neck pain. So again, a reasonable study, 152 participants, and they had to present with neck pain and with poor joint position sense and with impaired balance. And the training regime was 6 weeks. And so it was a factorial design where one group just got the manual therapy and specific neuromuscular training. Another group got that, but joint position sense and oculomotor training was added. In this group, balance was added to the basic treatment. And in the final group, both the joint position sense and balance training were added. And if we look at these results, again, you can see, by the way, that all of the methods decrease the neck pain intensity. As far as neck disability is concerned, again, all methods improved it at the beginning, although the one with manual therapy plus proprioception plus balance training actually improved it a little bit better. But if we also look at the actual impairments, for example, in joint position sense, or this is the improvement in joint position error, you can see that just doing the manual therapy and therapeutic exercise didn't have a great effect on the joint position error, but the best effect was from the joint position error plus balance. Those two, joint position error by itself, or training joint position sense by itself, improved. But if you did both programs, balance plus training of joint position sense, it was superior. And this is an AP displacement, or in other words, this is a balance measure. So we got some improvement in balance with the manual therapy and therapeutic exercise, but most improvement when we added balance training to the program. So again, it's showing the benefit of adding specific treatments or specific exercises to address the specific impairments. So there's now, I've just given you a bit of a sample, but there's now a considerable body of evidence showing that the various impairments can be effectively addressed by specific training modes, that there's no one size fits all exercise. There's no one size fits all exercise. You've got to actually prescribe them for the individual patient, depending on their presentation. But the exercise programs, and I'll show you later, are not complex. They are quite easy. The secret is in your assessment to know which impairments are present. It's important for effective rehabilitation that we have adequate dosage to normalize the muscle behavior. And also, there is a bonus analgesic effect of both the sensory motor and the neuromuscular exercises. So if we look at the physiotherapy management of patients with neck pain disorders, the evidence certainly supports a multimodal approach. So for example, the multimodal management approach will include pain management, so that would be a combination of our education, ergonomic modifications, manual therapy, and our specific exercise. And then it would incorporate rehabilitating the physical impairments in the articular system, as well as the neuromuscular and sensory motor systems. And then once we've got the basic physical impairments rectified, you're looking at specific skill training and graded therapeutic exercise so that you restore participation in their work or sport. The patient's always got to be an active participant, because you must have, you can have the best exercises in the world, but if the patient doesn't do it, it doesn't help. So in rehabilitation, we've got to manage the presenting episodes, and patients want pain relief, so we certainly want to give them pain relief. But we've also got to have an emphasis on prevention. So the patient must have a maintenance program and a relapse prevention program. So if we look at the type of neuromuscular and sensory motor training that we would advocate, we put it into two phases. So the first phase is rehabilitating the neuromuscular and sensory motor control. So that is low load exercise to target specific muscles. And we aim to improve their activation and their control capacity of those deep muscles in particular to start with. And then we need to train the coordination between the layers of the neck muscles and the axioscapular muscles. And we need to improve their activation to improve their feed-forward response. So that's for neuromuscular training. For the sensory motor, as necessary, we would train joint position sense or movement sense, retrain balance, eye movement control, or eye-head coordination. But we would look, as far as neuromuscular control is concerned, is to get that behavior between the deep and superficial muscles correct. And then once we've done that, we will actually progress them on to training endurance and strength to their occupational demands. Now, as I said, the exercises aren't particularly difficult. So I'll just give you a couple of examples. So for example, in the neck extensors, we'd concentrate first on activating the suboccipital extensors with a craniocervical extension action, the suboccipital rotators with a C12 or an upper cervical rotation. And what we find in patients that many of them can't dissociate the upper cervical rotation from their lower cervical spine. And so that often involves some proprioceptive training as well. And then we'll train the cervical extensors, and this looks rather funny, but we actually train them to be able to extend their neck without extending their head. So in other words, they keep their head in a neutral position. And what this does is it mechanically disadvantages muscles that attach to the skull, like splenius capitis. So in other words, we can direct the exercises more to the deeper extensor muscles. But once we've got those muscles working well, we then progress on to an endurance and strengthening program. Now for the neck flexors, which are sometimes a little more tricky, but often the patients, again, it's a mixture of poor muscle activation and movement sense. So often to start with, we've got to actually train the craniocervical flexion movement so that they are actually doing a pure rotation and not a retraction. So once they can activate the muscles, we then, most importantly, train their endurance. It's very important to train them in function. And we have done a study which actually shows that the posture exercise will actually activate the longus capitis, longus coli very effectively. Something that was shown with fine wire needle EMG many years ago. But this little clinical trial showed that you could decrease the activity in the sternocleidomastoid in the craniocervical flexion test when they trained in this posture exercise, in other words, train in function. And this is very important because when you're wanting to train motor skills again, repetition is very important. So they've got to have an exercise that they can do with minimal inconvenience repeatedly during the day. So once we've got it activated, then we start training the activation and control through movement, and then ultimately progressing to strength training. And it's the same sort of regime with the axioscapular muscles, so that we'll get muscles like the middle and lower trapezius, serratus anterior activated first, and then train them in function and progress to strength training. So it's the same sort of regime for the different muscles. I will mention something about exercise dosage because that's where there is great variability. So I just put this, this graph up to show the variation in deep cervical flexor activity. So this is in patient 1, this is pre-training, post-training, but you can see pre-training, they really had a very minor impairment. And so you can imagine that they get better pretty quickly, and they do. But in patient 2, who obviously had quite inhibited deep neck flexors, they are going to take a bit longer. And so it's very difficult to sort of prescribe, definite times. So it varies between a week or so to several weeks of training. So we showed in a trial that muscle coordination can be trained anything between 2 to 6 weeks, but some of the badder neck pains like the whiplash may take up to 10 weeks. The motor learning that I showed you before, it improved their timing of activation, but didn't bring it back to normal limits. And we've done a couple of pilot trials which suggests that we probably can restore it to a feed-forward response, but it probably takes at least 12 weeks of training. And again, strength training, depending on your goals and intensity of training, that can take anything up to about 20 weeks to get your strength changes. I wanted to show you that because everything these days tends to be discharge them as quickly as possible. But if you really do want to rehabilitate them, it is going to take some time. Now with sensory motor control, we use really the same for exercises. We can use the methods of testing. We can convert them into an exercise. So we can get them to practice relocating their head. We can get them to practice the accuracy of their movement, etc. And what we do is progress them, and you can progress the activity that they were doing by changing the starting position. So again, instead of doing joint position sense in sitting, you might do it in standing. We increase the complexity of the task and combine interventions. So for example, this person is practicing to improve their movement sense, but you make the task more complex by making them stand on one leg. So you're bringing in balance, etc., to make things harder. But again, as we saw, around about 6 to 8 weeks, but this will vary depending on how bad the impairments are. Patients must always be on a self-management program, and it must be customized. Importantly, it must be realistic, that the patient can do. And basically what it should do is replicate what you're doing in treatment, so that they continue the precise training of their neuromuscular and sensory motor deficits. It's also important to consider a maintenance program, because subclinical pathology, or in other words, disease progression, may perpetuate arthrogenous muscle inhibition. So we saw that people in remission still had problems with their neuromuscular system. And this graph really, I think, illustrates the problem of inhibition continuing. So I showed you this graph before where we just had pre and the 10 weeks post. But what I want to show here is the 26-week follow-up. So in other words, you can almost see that regression. You know, the patient is regressing. So in a way, patients probably need, once they've had an injury or pain, probably need a lifetime maintenance program to prevent you know, that reverting to the impairment and to counter this arthrogenous muscle inhibition. It always sounds dreadful when you say they need a lifetime maintenance program, but in fact, dentists have conquered this very well. I mean, dentists have us doing a preventative program by cleaning our teeth at least a couple of times a day. And it's almost, that is the way that I'll teach patients, that you're almost cleaning out your joints and muscles a couple of times a day. And a research-informed, rather simple exercise that they can do as a maintenance program is this posture exercise, because it really does activate their stability system, muscles like their lumbar multifidus and their longus capitis, longus coli. And the final thing is that we know it's a recurrent disorder, that they are likely to have a recurrence. So it's developing a program with the patients to prevent this relapse. So it may involve some self-mobilizations to their joints, resuming the important parts of their exercise program, and reviewing their work practices, etc. So let's end where we began. And so the current model of neck pain, as I said, it tends to be treated as a series of separate episodes, with the focus being on pain relief. And that's really the model I think that we've got to change, because it's failed. I mean, if you look at the Global Burden of Disease study, neck pain has not improved in the last 20 years of that study. It's probably getting a bit worse. So just treating it single episodes as pain doesn't work. So we should look at a change in focus, and which will involve a change in cost, which will involve a cost transfer. So at the moment, so much money is in this tertiary prevention, or dealing with repeated episodes of pain. And the big costs are here, whether it is surgical costs, whether it's treating patients repeatedly, conservatively, whether it's the costs of sending them to pain clinics, etc., etc. And it may be better if a lot of that money was invested in primary prevention, or at least in early stage secondary prevention. So in other words, once the patient has had an episode of neck pain, that rehabilitation is then not only once they have actually progressed. Because what's happening at the moment is, if they seem to be low risk, they're just given advice and told to go away. And it's like just waiting for them to get worse and worse and worse before we do a rehabilitation programs. So this model of care would have increased costs at the beginning, but hopefully reduce costs and reduce burden at the end. Okay, so my point is for this whole talk is that we've got to offer these patients adequate rehabilitation to try to decrease recurrent episodes of pain and to slow that disease progression. What we're doing at the moment isn't doing it. So thank you, and I'm happy to answer any questions.
Ramazan, you can turn on your microphone.
Yep. Erhat Harman, what do you think about cervical traction in cases of root compression? Do you recommend it for rehabilitation program for neck pain and cervical root compression?
Yeah, so there is one study that looked at cervical traction for radiculopathy, and it did have positive benefits. I think most of the studies, traction is a modality that has very little benefit for idiopathic neck pain or for non-radicular pain, but traction for radicular pain has some evidence of benefit. But again, so do other things. So, for example, from Sweden, there's been several studies looking at neuromuscular retraining in the management of cervical radiculopathy with relatively good results as well. But once you get to cervical radiculopathy, I think all the studies show that if we wait 2 years, the surgical outcome and the conservative treatment outcome will be similar. But the patient's got to put up with pain a lot more. So I think conservative treatment should be tried. It doesn't always work.
Thanks
I don't see another question, but I want to hear Aolu's opinion from the chiropractic point of view.
Yeah, I was actually trying to write it on the chat, and then so I can actually speak. Can I speak, or do I have to write it up? I can speak. Okay. Yeah. So, well, actually, I would like to thank you. It is a very valuable presentation from a public health point of view, and if I could just basically sum it up, championing with most of your inputs by staying EPIC, which is best evidence care, patient-centered, interprofessional, and collaborative. I think this is pretty much what it basically sums up to. And I actually teach a unit, or actually I lead a unit, which is called the Clinical Chiropractic Sciences Unit. It has 5 elements in it. One of them is a spinal approach. The other one is extraspinal. The other one is a soft tissue. The other one is psychosocial approach, which you haven't touched, and I would actually like your opinions on psychosocial approach. And the other one is actually functional rehab, and we have a wonderful exercise physiologist working with physiotherapists within our institution doing the functional rehab. So I would like your point of view on psychosocial approach, and also newly coming about terminology, contextual factors to improving with pain syndromes. What do you think about contextual factors on pain syndromes? Thank you.
With the biopsychosocial framework, I think, we operate within, I didn't mention any of that tonight, but yes, patients should be examined within a biopsychosocial context. I think we've got to be careful because so often the major psychological or emotional thing that's been found with neck pain patients, by the way, is fear of movement, fear avoidance, fear of movement. That if you actually look at the studies, there are thousands of studies well, hundreds probably, or at least dozens, where if you read the title, they'll say, you know, neck pain is associated with catastrophizing, or it's associated with this or associated with that. When you actually get deep into the article and really look at their data, the vast majority of the neck pain patients don't have major psychological issues. Once you get them into the chronic pains in pain clinics, etc., the percentages will increase. But the patients who come to outpatient type facilities for treatment, very few of them have major emotional or psychological problems. And in fact, I think the literature has done a great disservice to many of the neck pain patients. The other thing that I think is important is that if you look at a whole lot of the intervention studies, that things like anxiety, low mood, even catastrophization, by the way, decrease once you get rid of their pain. And so I think there's been a bit too much of a swing to the psychological side of the biopsychosocial model in the last 20 odd years. And I think it's time, and it's happening, that we're coming back to a more balanced view, which is the true biopsychosocial model, rather than the pendulum swinging from one side to the other. So I hope that's answered for the biopsychosocial framework. Sorry, what was the other question?
Where do you think?
I'll turn on his microphone.
Yeah.
The contextual factors to pain care, the contextual factors to patient perceiving that the treatment actually helped them, whatever the treatment may be, whether it's a passive surgical or conservative approach, or whether it's active exercise approach, just contextual.
Yeah, I don't know if I've got a very good answer for that, other than personal experience. I mean, the context of the treatment and the provider of the treatment and all of that sort of thing is always going to have an effect. And how much you tease it out, I don't know. We did one study, which was the headache, the RCT on cervicogenic headache. And we looked at the patient's locus of control. And it wasn't, in the end, it wasn't dependent on the practitioner. It was actually more dependent on the therapies given, whether they got better or not. So, I mean, I haven't got a really good answer for you, other than you've always got to consider it, and it's quite hard to measure it.
Thank you. Ramazan, continue the questions.
Thanks. Where do you think the role of facet blocks and muscle injection in neck pain?
What also about Botox additionally?
Yeah, if we go to the facet blocks and all of that sort of thing, I think they've got a place. But I think they've got a place for people with really quite marked disease, degenerative disease where conservative treatments can't help. I mean, I've treated, a lot of my clientele have been whiplash, and I also I had a specialty in headache, the neck-related headache. The vast majority of patients will respond well with conservative care, but there is a percentage who, in my thoughts, their pathology is just too advanced to be helped by conservative care. And in those cases, some of the facet blocks, etc., I think can be very, very helpful. As far as the injections in a muscle, I mean, they can be a pain relieving thing, and Botox can be a pain relieving modality. But you can decrease those muscle pains and the trigger points by better rehabilitation. You know, I can change muscle tenderness, etc., by getting what we call a reciprocal relaxation of the muscle, by getting the correct muscles to work. The muscles that are overactive and getting sore and painful spots in them, they relax. So I can see great roles for facet blocks or whatever. The injections into muscles, there are better alternatives in my view.
Okay.
Thanks for the answer.
Thank you very much for your answers. And I cannot see any other questions. So I want to ask mine.
Mm-hmm.
I wonder, I don't know if I missed, did you mention about the post-operative period, if patient underwent an operation for
No, I
cervical
didn't.
disc operation? Should the patient make some exercise? What kind of exercise the patient should do? And when the patient should start the exercise, if he or she must do?
I think that there has been one study in Sweden that's actually looked at post-operative patients. I think they definitely should be exercised. For example, if you're doing an anterior surgical approach, one of the most important muscles is longus capitis and longus coli, which you'll dissect, you know, to get to that anterior part that you need to. So I think it's very, very important that post-surgically they are exercised. Now, when can it start? It can literally start almost immediately, because if you use a motor control approach, the exercises are extraordinarily gentle. So, for example, training the deep neck flexors, you are practicing the nodding movement to say yes. So the load is no bigger than that to start with. So you could start relatively early, but you start very, very gently with low load. But I think it's very important to get those muscles going. Very, very important, because they inhibit so quickly. And the study from Sweden showed that so many months afterwards, they hadn't recovered their function. So I think it's important to do post-surgically.
Yeah, as I understood, you can start to next day after the operation, gently.
Yeah, well, you could. The minute you allow the patient to say yes,
Okay.
they can start to exercise, basically, because that's the movement you're going to use and you're going to do it in a supine lying position. So yes, there's no load, so they could start straight away.
Okay, thank you so much.
You would strengthening, you know, exercises with load, I would leave to several weeks down the track. So you just start them off gently to start with.
Okay, thank you very much. It was a excellent lecture and very informative for us. Thank you so much and goodbye. I want to thank everyone who joined our conference today, and I want to thank you again, Professor Jull.
Yeah, my pleasure. My pleasure.
Thank you so much.